Well, good morning. As usual, I'm so excited. And thank you all for being here. Your presence makes all of us very special. And I must appreciate Dr. Ranjit, Dr. Mohan sir, Dr. Anjana, and the entire team for this wonderful, wonderful Congress. And it's an honor and absolute privilege to stand in front of my teachers like Professor Jagat Narula, Dr. Nigam, Dr. Sujay Ghosh. These are all icons of medicine, not only in India but globally. So thank you for a wonderful opportunity, and I'm going to continue my talk where Professor Oman left. He talked about the most deadliest complication that can cost a life. And to continue that, I'm going to talk to you about one such complication which can make a life of the patient miserable, really hell, and that is diabetic neuropathy. I appreciate my friend, my classmate, Professor Atul Ingre. Thank you very much, Atul, for being here for a good morning. It's a pleasure to see you all. I don't have any disclosures for this talk, but I'm going to be really simplistic and I'm going to be really practical because I want you people to manage diabetic neuropathy properly. Unfortunately, to me, it's a forgotten complication. We do not put any of our attention while we are managing all those complicated areas. But this is one such complication which is preventable, but if it happens, can really be a limb-threatening situation. And if it becomes a limb-threatening situation, it can become a life-threatening situation. Most of my talk is by Dr. Bodman's book, and it's one of the wonderful books. If at all you are interested in, you can go onto the internet and read this. It is one of the great books. Time will stop me from discussing all the details, but we can all have these questions in the Q&A session. How would you define a neuropathy? And this is San Antonio consensus statement almost 3 decades ago. And after that, believe me, there are a lot of work which has been put in managing different complications of diabetes, but unfortunately, hardly any work has been done to see to it that we stop or prevent people getting diabetic neuropathy. So diabetic neuropathy is a condition which is a demonstrable, it's a visible complication. It's a symptomatic complication, either clinically evident or sometimes in a subclinical setting in the patient, especially with diabetes or even pre-diabetes, and you need to be very active and proactive in searching them. This is a mind-boggling data. 50 to 60% of the people are going to develop some kind of a neuropathy in their lifetimes. But mind well, if you manage diabetes and the searching and the screening for neuropathy, this is a preventable complication. Many of them are told by the physicians or the endocrinologist or the diabetologist treating them. And unfortunately, 1 in only 7 are sensitized amongst us to really talk and understand about diabetic neuropathy. So neuropathy, friends, is a complication of diabetes which will touch almost every system. You talk about any possible complication, there is some role of neuropathy coming in. Even in the heart failure with preserved ejection fraction, autonomic neuropathy plays a role. Early diagnosis is always a decider. Aggressive treatment and early treatment and a good glycemic control will always slow down the progression, if at all, because if it develops, it is one of the most painful and unfortunately suffering complication that the patient suffers from. Neuropathy is always a diagnosis of exclusion. Good glycemic control genuinely matters. So understand that we need to screen each and every type 1 diabetics at least once in 5 years. Make him or her to undergo a proper screening once in 5 years at least for diabetic neuropathy, and screen at the diagnosis and every yearly in the patients with type 2 diabetes. And especially when Dr. Mohan and me had an opportunity to write an editorial in JAPI about the different clusters of diabetes in Indian subclass, and we have realized that it is that severe insulin deficiency and the combined insulin deficiency and resistance clusters, they are very vulnerable to develop microvascular complications like diabetic neuropathy and diabetic nephropathy. Most symptomatic challenge, but unfortunately, we do not still know the prevalence because population-based studies are not done. Most of the data which has been published here, the clinic-based data, even Mohan sir's data has been published in Chennai Cups and Cure study, they have probably reported around 30%. Now 30% of 101 million diabetics is 28 million, sir. It is bigger than a population of Australia or New Zealand or most of the countries. Now that is the vulnerability of the patients of developing diabetic peripheral neuropathy. Mostly it is a distant peripheral neuropathy and contributor of the reason for limb loss and foot ulcers is diabetic peripheral neuropathy along with the vasculopathy. And understand, if you reduce down A1C by just 2%, you are genuinely reducing down the complication of neuropathy by 60%. How do you classify them? Again, 3 decades ago classification, that is Professor Thomas classification, which got published in 1997. Symmetrical neuropathies, and we have focal and multifocal neuropathies. In symmetrical, you have got sensory, motor, and autonomic. And of course, focal and multifocal neuropathies, mononeuropathy multiplex, plexopathies, axonopathies, radiculopathies, and cranial nerve involvements. Now let's talk about symmetrical neuropathies. The commonest neuropathy that happens is generally the long fiber neuropathies. So that is the reason why it involves more limbs and especially lower limbs. So distal pure sensory or sensory motor polyneuropathies can be the small fiber neuropathies or large fiber neuropathies. But understand that they will present to you with numbness, paresthesia, which will slowly begin at the toes and they'll climb up. It will be a climbing up, so they'll involve toes and then ankles and they'll slowly come to the feet and then climb up to the thighs and up 4 feet. Mostly they will involve the type A fibers, the long fibers of delta quality, but sometimes the unmyelinated small C type of fibers are also involved. Whereas on the contrary, the small fiber neuropathy will be the most symptomatic one. So the patients will not come to you with the symptoms of paresthesia generally to you when they are actually developing a long fiber neuropathy. But people with small fiber neuropathy will surely come to you saying that, sir, I feel that my feet are on fire. There are a lot of pins and pricks. Ask somebody who spends a sleepless night, developed allodynia, developed that, I cannot even bear the touch of my own clothes. Now that is the pain that these patients they develop. And they also will have the change in the temperature and the proprioception. So the long fiber neuropathy will always have a feature of loss of vibration, loss of proprioception, and also there will be a deep tendon jerk loss, and there could be on EMG nerve conduction, there could be an abnormal nerve conduction as well. But there are a few other types of neuropathies that will also come into the picture whenever you are talking and managing diabetes. Treatment-induced neuropathies, and we all know that metformin can cause or worsen neuropathy. Sometimes in a grossly uncontrolled sugar patients, if you induce them on insulin can worsen, but there is a reversible neuropathy, but initiation of insulin can worsen the neuropathy symptoms. Hyperglycemic neuropathies generally are new to the diabetes and they are completely reversible. Once you control sugars, the neuropathies will reverse down. Acute painful neuropathies, generally small fiber neuropathies, striking hypersensitivity and allodynia are the characters of this. Most unwanted is what we know as CIDP, chronic inflammatory demyelinating polyneuropathy, will produce a rapid symmetrical weakness and demyelination, and there will be a clear demonstration of conduction defects on the EMG nerve conduction. And lastly, autonomic neuropathy is a completely different ball game. I am not going to touch upon them at all. Focal and multifocal neuropathies are cranial neuropathies. We all know about it. The third, the fourth, the sixth are the commonest one. The asymmetrical polyneuropathy is what we know as amyotrophy, the diabetic amyotrophy. Rapidly progressive, but completely reversible. So treat it and treat it early, diagnose it early. Truncal mononeuropathies and limb mononeuropathies are another forms of focal and multifocal neuropathies. Truncal neuropathies, unusual, rare, but can present you with acute pain in the back, chest and abdomen. There could be associated sensory loss or dysesthesia, altered sensations. Amyotrophy is rewarding if you pick it early. It will present you with the asymmetrical proximal muscle motor loss or muscular function loss. There will be invariably the deep tendon jerks which will be absent. There will be weakness and wasting, especially of the hip and the knee and the quadriceps muscles. There will be a loss of deep tendon jerks. There can be subtle sensory features, but they generally will present to you with acute weight loss. The cause is generally inflammatory, and if you treat them, it is completely reversible. So quickly coming to the etiology of diabetic neuropathy. We have heard about just the glycemia part of the story, but there is always a vascular, a metabolic, a neurotropic, or a neuropathic and immunological and inflammatory challenge which is always on board. And there are multiple pathways. Sujay has written a beautiful article on polyneuropathy, and we have published it in JAPI, where we have talked about polyol pathway activation, the protein kinase C activation, the deposition of the advanced end glycation products, the essential fatty acids challenge that is there, and polymerase activation. These are all few of the challenges which actually manifest in diabetic neuropathy. What are the clinical expressions? Generally, majority of the times, 30% of the patients will not have neuropathy if you have tried to screen them early and pick them early. Then a lot of them will be picked up by the active investigations like electrophysiology or quantitative testing or biothiometry. Clinical examination is not really rewarding unless until you do it specifically. So only 10 to 20% would be diagnosed on the clinical examination, and 10 to 20% will have bad sensory symptoms, and they'll present to you with symptomatology. That is most important. So get sensitized to the symptoms. Generally will present to you with glow and stalking type of loss. Lower limbs are always more involved than upper limbs. Numbness, paresthesia, dysesthesia, weakness, allodynia, that I have already told you about that. Spontaneous pains are the classic signs of diabetic neuropathy, and there can be evoked pains like hyperalgesia, allodynia, and hyperpathia. These are all clinically elucidable signs or eludable signs. So whenever you are following the screening techniques, if you are in the primary or the secondary care, just look at the table and you will realize that simple history taking, a good clinical examination, monofilament testing, and vibration testing, you don't require even biothiometry, is sufficient in your primary care practice. Dr. Ranjit will agree with me. There is a definite scoring system, what we know it as a neuropathy disability score, where we are using tuning fork to find out about the vibration potential. And mind well, it has to be always 128 Hertz tuning fork. Please do not use any other else, otherwise you will be messing up with the patient. Temperature testing is a lot of times a challenge, but I have invented, Jagat sir, a very simple technique. We all sit into the air-conditioned consulting rooms, right? So my friend has suggested that, have a small wooden log, a stick, on half side, cover it with the steel plate and keep it there in the air condition or in the refrigerator. With the temperature going down, that steel plate will become very cold, but the wood will not. That is sufficient. You don't have to touch with the heat or hot thing, but the simplest way of touching and simple practical tip is this, that try and do this. I am doing this in my clinic. Pinpricks and acrylic reflexes, any score more than 3 indicates that there is a possibility of a presence of neuropathy. Be mindful of all these feet. If these feet are there, that tells you that these are the people who are neuropathic patient, or they are the people for a Charcot's joint patients. So use of monofilament in clinical practice is mandatory. Those who do not have monofilament in your clinic, you are not completely examining your diabetic patient for sure. Similarly, tuning fork of 128 Hertz is extremely important. No patient should lie down on your examination table with socks or shoes on. No patient. They should walk inside your clinic barefoot, look at the veins. Quite possible that large fiber neuropathies will present you with wet feet. You will be able to see the sweat and the feet impression with the sweat on your floor when they walk in. There could be dilated vessels that you will not miss because of an excessive blood flow, and these are the feet, those are vulnerable to develop Charcot's joints. Small fiber neuropathy, will always be symptomatic, and I'm more than sure about it that you are not going to miss them. Ask for the associated symptoms like insomnia. Majority of the patients will tell you that I don't sleep well, sir. I cannot get sleep. Something is happening in my feet. Something is there. I don't know what happens, but there is something like, I'm not able to sleep. Anxiety, depression, weight loss will alter the quality of life of the patient. Autonomic neuropathy, it's completely different ball game, completely different session altogether. I will not dwell into it in details. So foot care, if you practice, always do the basic things right, my friends. It is extremely important. Last 4 minutes I have, 2 minutes I'll spend on just the treatment part. Unfortunately, not a lot of work has been done. We do have wonderful drugs for treating all the other challenges, but unfortunately, we have forgotten that diabetic neuropathy also needs an attention. So try and halt the progression should be the primary goal. Intervene early, that is the decider. A good glycemic control is the backbone of the success of the therapy, and that will surely try to give you benefits and always try to alleviate the pain. Majority of the times, once the patient has come to you with symptoms and signs, what you are trying to do is only last thing. Rest of the things you have lost the boat, sir. And then the next part comes is try to stop somebody developing the diabetic foot and the foot related challenges. So education, dosing and titration of the dosing, individualizing therapy and combination therapy are the crux of the treatment successes. Current therapies, we have antidepressants. Don't get surprised, they play a major role. But what is most interesting is anticonvulsants. And what anticonvulsants you are using? Do we have any anticonvulsant that we use? Yes? Divalproate. Topiramate. Okay, I'm going to show you and surprise you with this answer. Right? Antiarrhythmics. Do we use antiarrhythmics? How many of you know about it? Topical agents, we do have. NMDA receptor blockers, surely we have. And of course, opiates and other type of analgesics, surely we have. Gabapentin and pregabalin are anticonvulsants, mind well. How many of you knew this? These are anticonvulsant drugs. So the only approved drug therapy by American Diabetes Association and most of the association, including RSSDI and Endocrine Society, are only two drugs, gabapentin or pregabalin, and the tricyclic antidepressants or duloxetine. You can use them as a monotherapy or in a combination therapy and keep on titrating. When you are using the tricyclic antidepressants, generally these are the drugs like amitriptyline, one of my favorites, which I use commonly. I start low with just 10 milligrams and slowly step up to 25, and I never ever have crossed in any patient 100 milligrams. Watch for the side effects because these are all drugs which will have side effects. Then the SSRIs or selective serotonin uptake inhibitors will also have a role to play. The drug that we commonly use is duloxetine. Unfortunately, not very well tolerated by the patients in even a smallest possible dose of 10 milligrams, sir. But we very watchful. Other anticonvulsants like topiramate, somebody said, lamotrigine, oxcarbamazepine, levetiracetam, all these four I have used in my clinical practice. I do not have too much of experience with zanosamide or even with the tiagabine. Opioids, the only opioid that I use are two, fentanyl patches and of course tramadol sometimes, but that too only in extremely painful situations. Local and topical agents like capsaicin are coming well into the picture. Role of neurotropic vitamins is very controversial. I may not recommend it. Interventions will come into the play in drug-resistant patients, those who are continuously symptomatic. So all our anesthetic and pain management consultants will come into the play. Nerve blocks and neurolysis and all that will come into the picture. There are a few emerging therapies like botulinum toxin, lacosamide, and all those things, but these are all just on the horizon. They are not really proved to be beneficial. So to close, friends, as I come to the end of my talk, diabetic peripheral neuropathy needs your attention. Early detection is the primary thing that you must all follow. A good education and a good clinical examination and proactive history taking and good examination will definitely do and prevent the neuropathy and better management. Thank you very much for your kind attention, folks. I'm really touched, and thank you very much.